Dear chairpersons, dear colleagues, ladies and gentlemen, it's a great honor to speak here today and present primary data from the DETOX trial. Here are my conflicts of interest, which I don't have. We received Swedish money from the Swedish Heart Lung Foundation, the Swedish Research Council, and the Swedish Foundation for Strategic Research. No funding from industry or for-profit organization was received. A few words on the background. Oxygen therapy has been used for more than a century and is widely recommended by guidelines, despite limited evidence. The ESC gives it a strong Class 1 recommendation based on level of evidence C, expert opinion. The rationale behind this recommendation is the belief that increased oxygen delivery to the ischemic myocardium reduces infarct size and subsequent complications, such as heart failure or arrhythmias. A controversy has come up the recent years where experts have been arguing whether this therapy is actually more based on tradition than on scientific fact, and there might even be risks involved. This discussion was fueled by the publication of the Australian AVOID trial showing larger infarct size in the patients on oxygen. A Cochrane meta-analysis, however, 2016 concluded that there was still no high-quality data from large enough RCTs available, and that the clinical effect of routine oxygen therapy in normoxemic patients with suspected AMI remains uncertain. To the study design. The DETOX trial is a registry-based randomized clinical trial based on the SwedeHeart Registry, a national comprehensive quality of care registry in coronary care where all 69 Swedish hospitals with CCU capacity participate. The coverage is above 90% of all myocardial infarctions in Sweden per year. The trial sponsor was the Karolinska Institute in Stockholm, and the academic research organization was supplied by the Uppsala Clinical Research Center. Inclusion criteria were simple. Patients who had classical AMI symptoms such as chest pain or shortness of breath within 6 hours, who were 30 years of age or older, who had an oxygen saturation of 90% or above on pulse oximetry, and significant ECG changes indicating ischemia based on the universal definition of myocardial infarction, or elevated troponin levels above the local decision limit for AMI were included. Excluded were patients who had continuous oxygen therapy at home or had suffered of cardiac arrest prior to enrollment, as in these instances, high-flow oxygen is still recommended. To the study enrollment. At first medical contact with the emergency medical system, the emergency department, the coronary care unit or cath lab, patients were assessed for eligibility. Eligible patients had to leave initial oral informed consent, which was confirmed in writing within 24 hours. Then they were randomized online using a randomization module embedded in the SwedeHeart Registry. Patients were randomized to oxygen delivered by an open face mask at 6 liters per minute for 6 to 12 hours, or ambient air. All data analysis was performed through the Swedish Population Registry and SwedeHeart. The primary endpoint was death from any cause within 365 days after randomization in the intention to treat population. A few words on sample size and analysis. We chose a two-tailed superiority design because we wanted to be able to show both potential benefit and harm. A clinical relevant effect we defined as a 20% relative risk reduction. 1 year all-cause mortality in AMI patients was estimated at 14% based on published and historical data. With a significance level of 0.5, 90% power, 2,865 patients were needed per group. We extended group size to 3,300 patients to have some margin for patients not completing the trial or crossing over. So to the results. 6,629 patients were randomized in DETOX under less than 3 years. 3,311 patients were assigned to the oxygen group and included in the primary ITT analysis, of which 62 developed hypoxemia. 297 patients did not complete participation, and the most common reason was refusal to continue oxygen therapy, leaving 3,014 patients for the secondary per-protocol analysis. 3,318 patients were assigned to the ambient air group and included in the primary ITT analysis, of which 254 developed hypoxemia, a significant difference compared to the oxygen group. 106 patients did not complete participation, leaving 3,212 patients for the secondary per-protocol analysis. No patients were lost to follow-up for the primary endpoint. To give you some perspective on the size of the DETOX trial, you can see here on this slide in the second row the Cochrane meta-analysis I mentioned before, summarizing all the trials below to a bit more than 1,000 patients. DETOX had more than 6 times that size. Baseline characteristics and clinical presentations were similar in both groups. The median age was 68, predominantly males. Risk factors such as smoking at 20% of the patients, half of the patients had hypertension, about 20% again with diabetes, 20% with previous MI, and about 16% with previous PCI. Most of the patients came by ambulance, and the median oxygen saturation at presentation was 97% in both groups. Looking at in-hospital procedures and complications, the median duration of oxygen therapy was 11.6 hours. The median oxygen saturation at the end of the treatment period was 99% in the oxygen group, 97% in the ambient air group, a significant difference. No difference, however, in procedures or acute heart failure medication except for the use of IV inotropes, which was more common in the ambient air group. Considering complications such as reinfarction, cardiogenic shock, cardiac arrest, or death, they were similarly distributed in both groups. Concerning discharge diagnosis, remember that we included patients with suspected myocardial infarctions due to the fact that at first medical contact and initiation of oxygen therapy, the diagnosis is not certain yet. The diagnosis was similar in both groups. 75% of the patients had their myocardial infarction diagnosis confirmed. Another 15% received angina or other cardiac diagnosis. 10% of the patients received non-cardiovascular diagnosis. Now to the primary endpoint up to 365 days. As you can see here, mortality was very similar in both groups, 5% in the oxygen treatment group, 5.1% in the ambient air group, resulting in a hazard ratio of 0.97, a p-value of 0.8. When looking at the primary endpoint at 365 days in pre-specified subgroups, you can see in this slide in the column to the left that we looked at the per-protocol population, similar results. We compared patients with or without AMI diagnosis. We compared infarction types. We compared males and females. We compared patients with age above or below the median. We compared patients with risk factors such as smoking, diabetes, chronic kidney disease, or anemia, patients with saturations above or below 95%, and patients with previous MI or previous PCI. And as you can see in the center column here, there was no significant difference in between the groups in any of the pre-specified subgroups. Finally, when looking at myocardial injury by highly sensitive troponin T, in this figure you see the summary, the median of the highest measured value during hospitalization. And you can see virtually identical results in both groups, resulting in a p-value of 0.97. So in conclusion, dear chairpersons, ladies and gentlemen, in this pragmatic, registry-based randomized clinical trial evaluating supplemental oxygen versus ambient air in patients presenting with suspected myocardial infarction who did not have hypoxemia at baseline, we did not find a beneficial effect of oxygen treatment with respect to all-cause mortality at 1 year. The absence of an effect of supplemental oxygen on mortality was consistent in all pre-specified subgroups, regardless of baseline characteristics and final diagnosis. On behalf of the steering committee, I want to thank all the DETOX sweetheart investigators and the staffs of participating hospitals and EMS units for their commitment to this trial, and most of all the patients willing to participate. If you're interested in more details, you can find the full article on the New England homepage from now. Thank you very much for your attention.